without further delay, we will start with the first speaker, Dr. SHREYAS RAMAMURThy, who will give an overview of the biometry devices.
Good morning, everyone. And at the outset, I'd like to thank Dr. Sri Ganesh sir for inviting me on his course. And it's always a pleasure to be a part of his session. So I will be taking you all through an overview of the biometry devices. And like sir was saying, today the combination of biometry devices and advanced biometric formula is what is really making cataract surgery into a refractive cataract surgery. And truly, we have a variety of choices today. And as we speak, more and more devices are getting included into the market. So I'll try to present an overview, try to give some of the concepts, while I will not be able to cover the entire gamut of devices. So we have ultrasound biometry, optical biometry, and topo and tomographers, OCT based biometers as well. Now, ultrasound biometry might sound as if it is extinct, but even today, a very well done immersion biometry can give extremely accurate results, a well done keratometry. I keep mentioning this every single time when I'm given this topic, that there are still a few centers of ours where we don't have an optical biometer. But all those centers still do toric IOLs, multifocal IOLs, and their results are comparable to those of the centers where we have optical biometers. So it's important that we use only immersion, don't use a contact technique. Ensure your spikes in your scan are good. You should have those specific 5 spikes required. And once you have a good quality scan, also you can use in help in adjusting the gain. Use a higher gain when you have require a lower resolution, like for example in denser cataracts where you just need the axial length. Can decrease the gain if you have a lot of reverberations, like in a silicone oil filled eye. So by making some of these adjustments, fine tuning, ensure you have a specific biometrist who does this. Even by using an ultrasound biometer, you can have excellent results. The only challenge comes when you have a very high myopic eye, where you have a staphylomatous eye, so where the visual axis and the anatomical axis does not coincide. So you might be measuring into the depth of the staphyloma, which will end up in overestimating the IOL power. Whereas with the A scan, because the patient fixates, you are measuring more or less over the fovea, and we'll talk a little bit more about it. There have definitely been advances with the IOLmaster 500 to 700 and LensStar 900. And essentially, what is happening now is most of these are now turning into B scan biometry. That is, you are able to get a cross section using swept source OCT. You are able to measure the lens thickness, anterior chamber depth very, very accurately. So I'll take you all through each of these components, starting from keratometry. So with keratometry, while manual is still stands, can be used as a reference, but more or less we have switched over either to the optical biometers for accurate keratometry, and there is excellent agreement between all the devices. So whichever one you have, you can be happy using it. Tomography is also very useful, especially in post LASIK eyes. And irrespective of the tomographer which you're using, Pentacam, Galileo, Sirius, all give excellent outputs. Pentacam has a specific EKR report as well, which can be used in post LASIK eyes. But specifically coming back to the biometers in terms of keratometry, it's important that you know the number of points and the area which is being measured, because all the formulae that you have are based out of our biometers on the central 3 mm. So sometimes if there is a discrepancy between your SIMK values on your topographer and your IOLmaster, you would rather go with your IOLmaster, because the formulae are actually adapted to the readings which you get from the IOLmaster or the LensStar. So specifically regarding IOLmaster, one additional advantage that you have is something called the telecentric keratometry, where essentially it's a little more idiot proof that even if the patient is not cooperating very well, or the person who's taking the scan is not doing it accurately, even if the focus is not spot on, the distance between the spots remain the same. So the area over the cornea where you're measuring remains the same. The zone remains the same. So even with minor discrepancies in terms of the patient not being able to position their head properly, you'll still get accurate scans. But what has really been a game changer is the presence of total keratometry. Now, the total keratometry is essentially giving us a torus model where we are able to project the points which we're using for measurement on the anterior cornea onto the posterior cornea to get a posterior torus fit as well. And therefore, we get the traditional anterior keratometry, you get the posterior keratometry, and the sum total, which is the total keratometry. We all know now that the posterior corneal power and astigmatism have a great role in terms of our IOL power calculation. And the best part with the TK is that you have formulae which are adapted to the total keratometry, and it does not require any modification and change to using other formulae. So you can use the ULIP compatible formulae. There has been argument on whether you can take the measured value versus a value which is mathematically already available on the online calculators. And it was earlier shown that the mathematical values were superior to the measured values taken from any of these Scheimpflug devices like Pentacam, Galilei, which also give you posterior corneal astigmatism. This is primarily because the values taken from these measurements are not directly suited for the formulae which we are using. So whereas with the Barrett TK formula which is available now, you can use the TK provided by the biometer, and you can use them in the Barrett TK Universal 2 or the Barrett TK Toric, which gives you excellent results. And I think in all our practices, most of us have switched over to using these for all our patients. And definitely it has improved our outcome in toric patients. And even in post-laser refractive eyes, rather than using the overall calculators, we've moved on to using the Barrett 2K TK, which is giving us better results than the Barrett TrueK or the ACRS average or Shamas. And it is not just the Barrett TK, but also the Haigis TK, which is performing very well. So primarily that the total keratometry is giving us more accurate measurements of the posterior cornea, which is now compatible with the formulae which we are using. And whether you're using the Haigis or the Barrett, excellent results are available now. You also have angle alpha and angle kappa measurements which are provided. And as far as keratometry is concerned, definitely this is the way to go. Quickly moving on to the other measurements, the anterior chamber depth measurements, while are very, very important now because the ELP, which is central to most of the formulae which you're using, is also corely dependent on the anterior chamber depth measurements. The earlier IOL Master 500 used to measure from the epithelium. Now you have the option of using the endo or the epi as well. The earlier iterations were not very accurate with pseudophakic eyes, but now with the B-scan biometry, you have excellent measurements with the IOL Master and LensStar as well. The axial length, again, very good, strong intermethod agreement between different devices. Even with the ultrasound, if you can see here with the immersion, the difference is only 0.04 millimeter difference. So it's very, very good. The best part about the swept source OCT is apart from just looking at the fixation. Now, if you have a patient who's not as cooperative, but here you can also image the foveal pit. This makes it even more accurate because you know for sure whether you're measuring at the right point. When the foveal pit is imaged properly and you have good fixation, you can see that the readings are extremely repeatable and the IOL power is exactly the same. Whereas wherever the foveal pit is not visible and it's not imaged appropriately, you have a difference in keratometry as well as in axial length, which gives rise to almost a diopter of difference in the IOL power between readings. So by imaging the foveal pit accurately, you also get very, very repeatable and recordings, which can be used for all your patients. Again, better ELP measurements, like I mentioned, both in the pre and post-operative period, because you get better anterior chamber depth measurements. It also gives you a kind of faint image. It's not a replacement for your OCT. But then when you see some macular pathology, you, instead of directly counseling the patient for other premium IOLs and then getting an OCT done, this will kind of give you an initial idea whether this patient is a possible suitable candidate for premium IOLs. The penetration of these swept source OCT devices is also much better, and it's very, very few cataracts nowadays that you're having to shift to the immersion. Most of them we are able to do with the optical biometer. The most recent advancement is combining the biometry with the topography, and we have a variety of devices nowadays, right from LS900, the Aladdin, which is very useful. We have it in a few centers. The IOL Master 700 also gives you a very simple Placido image. The Galilei G6, Zima, Tomy, Argos, again with excellent penetration, and the Pentacam AXL. So some of them were primarily Scheimpflug devices, which have now incorporated axial length, and the other way also, where the biometers are now giving us a simple Placido device image. And multiple studies have compared different devices, that is the Scheimpflug devices, which provide the axial length versus the classic biometers, and they have found that the results are quite comparable, and you can use any of these devices. This is just a sample printout of the Aladdin, where you get a reasonable normalized axial map. You also get the different keratoconus screening indices, the pupil data, Zernike analysis, all of which in a single image. And it's extremely useful even in regular corneas as well as irregular corneas, in keratoconic eyes and post-LASIK eyes as well. And this is just a printout from the IOL Master 700, where you can see that it is quite comparable. Even though the measurement data points might be fewer than the Scheimpflug devices, it's quite comparable and gives you a fair idea. Almost all our patients now, we are running them through the Barrett toric calculator. Even if you find that there is very little astigmatism on the anterior cornea, the posterior corneal astigmatism can contribute. And you will be surprised to see that even sometimes as low as 0.5, 0.6 on the anterior cornea, it will suggest a T3 model. So it's good to run them through your calculators. So with excellent imaging devices and with the availability of 5th generation IOL power formula, which I think we'll hear in the next talk, imetropia for any and every patient has become a real possibility. Thank you so much for your kind attention.
Thank you, Dr. Shreyas, for that excellent coverage of biometric devices. And though we have technology advancement and then newer devices coming in, like he said, if you cannot afford these devices, you can still use immersion biometry. And many of the formula are available online.
Yes,
like with the APA CRS, you have the entire Barrett suite. So you have access to that. So you can use the correct formula to get an accurate result, even if you have an